Good. Age, gender, time frame. Okay, when you go to form the chief complaint, what is it that makes endocrine so different than everything else? Right? You've got to recognize the pattern. That's always what makes endocrine different than every other system is you're not going to find a nice tight shortness of breath. You're not going to find a perfect chest pain. It just isn't work that well. So as you go through the key hormones in your mind, don't have a scattered, mumbled, jumbled bunch of symptoms. Have a way of thinking about it. So when I say, how do we think about thyroid? How do you organize the symptoms of that system? Well, every time I say thyroid, I've learned it really helps me to think about it in evolution. You get a thyroid when you go from cold-blooded to warm-blooded. You generate that heat by creating inefficiency in all your molecular pathways. Good example are the ATPases become inefficient, and you uncouple the mitochondrial electron transfer chain. Everything's inefficient, generates heat, voila. And then you say to yourself, okay, so that means the temperature regulation must be in the hypothyroid. Because remember, the hypothyroid is the great outside-inside coordinator. So the second you say inside and temperature, you got to say, how does the body regulate temperature? Right? And that's always going to be hypothalamus to the sympathetic nervous system. It has to be. That's how we get our vasoconstriction. That's how we get our shaking. That's how we get our sweating and vasodilation. So you always think of the hypothalamus intimately related to the sympathetic nervous system. So what must the hypothalamus talk to? What else in the brain must it have a tight connection to? Well, nucleus tractus solitarius. Right? It has to connect to that. So those two have to talk a lot to coordinate this, don't they? Okay. So then when we say, how do you think about hyperthyroidism or thyroidism in any kind, the first thing you're going to is you're going to talk about just basal metabolic rate. How much uncoupling and inefficient ATPases do we have? So that's when we're going to talk about the really big one, which is going to be temperature sensitivity. That's when we're going to talk about weight loss, even though you're eating. Right? That's when we're going to talk about things like how your skin and hair look, right? So this is where you get the smooth skin and the silky hair. The next thing you want to talk about is how it connects to the sympathetic nervous system. Yeah, put a little star by that. This is what your patients hate. And remember, endocrine is disproportionately females. So I can say without prejudice, no woman ever complained because she could eat like a horse and still keep skinny. Right? As a famous old feminist said, you can never be too rich or too skinny. So when you say, what are your patients going to complain about? They're going to complain about the sympathetic nervous system. So these are going to be your anxiety, tremulous. And then we get other things like mental changes. So that's what your patients hate. So you're going to key on temperature, weight, things like that. They're going to key on the anxiety. And then after that, we come into much more general things. So what do we think about if someone's over 65? Right? This is where we're going to put our old people because that's all they might have. So which characteristic arrhythmia do you just say hyperthyroid cardiovascular over 65? What are you going to pencil in?
AFib.
Absolutely right. I would argue if I could do exams, there would be questions that would just be mandatory pass questions. And one of them would be, you shouldn't get an MD if you don't know that a 68-year-old with AFib has to have a thyroid test. To me, that's just non-negotiable. It's just some things are more important than others. That's pretty much a given. And then after cardiovascular, then we get into the bone and muscle. So everything isn't equally important, right? Okay, so from there, we can talk about testing teaches pathophys. So when you say thyroid, we now have to come over from patient presentation to how do you think about the system? So when I say thyroid system, structure, function, adaptation, disease, what do you write when you say, how do we think about endocrine? It's always feedback, right? So you always start endocrine with feedback. So you're always going to say hypothalamus, pituitary, thyroid. It's just always going to be that. And always from the hypothalamus, you're going to have a releasing hormone. And always from the pituitary, you're going to have a stimulating hormone. You can just add in which one it is by the organ. And then that's always going to feedback with inhibition at 2 levels. It's just how it always sets up. So when I say structure and hypothalamus, now we're talking about the median sagittal section of the brain. So you're going to start with your corpus callosum to your fornix, come down to your optic chiasma. Now I'm going to really emphasize I'm in my anterior pituitary, really different than thinking about the posterior pituitary. Mammillary body, everyone's got their acute and chronic B1s. We're going to come across, there's my midbrain, pons decussation, and there's my medulla. Coming back down again, oh, there's my pineal. It calcifies, so you can always find it. Think about your Paranode syndrome. There's my tectum, and then off into my cerebellum, ooh, infratentorial. Little kids, ataxia, headache, tumors. And then I'm going to finish it off, and there's going to be my 9, 10 nucleus tractus solitarius. And you can see it just becomes a way of thinking. So then I'm going to add in my groove. There is my foramen of Monroe. So this is going to be thalamus to hypothalamus. So you can see when I say hypothalamus, I actually don't have a word. I have an actual structure in my mind, don't I? Okay, when I say pituitary, now all of a sudden I'm adding, remember, there's my dura right here. So every time you think about how the body relates to the outside world, to the inside world, that's my hypothalamus. It coordinates everything. It coordinates your marriage through oxytocin. It coordinates whether you're fertile or not, right? Because if you're breastfeeding, what hormone is it releasing?
Prolactin.
Well, every time I say prolactin, you're going to do that, right, for gonadotropins. Man, you don't want to get pregnant when you've already got calorie deprivation with one baby. So it regulates your sexual fertility. It regulates friggin' everything. So when you talk to your patient, we talk about the psychosocial human. Yeah, you always are thinking in your mind the hypothalamus. So that just makes the pituitary just this amplifier that's inside from the central nervous system out to the body. Got it. When I say thyroid, what do you think? So when I say thyroid, the first thing I expect you to think is it's embryology. Why do I always start with embryology and the thyroid? Every friggin' woman over 30 has a bump on her thyroid. Every friggin' one of them. If you don't think 30-year-old women and thyroid aren't a thing, you just come and call me in 5 years. They've all got bumps and they all have fatigue and these non-specific findings that intimately could be thyroid. So you always do embryology because this is going to be your neck masses. So whenever I say thyroid, I'm thinking about my swallow test, foramen cecum, thyroglossal duct, and there it is. And remember, it can keep going, so it can be mediastinal. Okay? But when we talk about now structure, surface, internal, tissue, cell, molecular, you got to show me that. So when I say, tell me now about the structure, watch what I'm going to draw. I'm going to draw a butterfly. But what am I going to draw right here? What am I going to draw right there? The pyramidal lobe. If you've never sort of thought about it, you just thought, oh, it's kind of like, okay, I guess I could have got that. It looks like a pyramid. But remember, why do I draw the pyramidal lobe? Because it reminds me of the embryology. That's the last dragging, trying to keep up with the pack group that actually come down from your thyroglossal duct. So there's nothing unique about the pyramidal lobe. It just is. But it's just a nice little reminder that all this tissue actually migrated down, and those were the people that just didn't quite keep going. They were good enough where they were. Now we're going to say, but how do you see the thyroid at the tissue and cellular level? So remember, when I take a piece of this, I'm going to be drawing the functional low power. When I say tissue, I mean a low power microscopic view. If you get a stain and you hold it up and you have good eyes, you can do a low power on a microscope. When you've been doing pathology after your first decade, you can hold a slide up and know what you're looking at. So it's sort of that transition of low power, almost the bare eye. That's what you mean by architecture. So for this, you're going to draw this. When you say, what's the architecture of the thyroid? I'm going to draw these, aren't I? Right? So those are my follicles. And remember, in them, all of my follicles are filled with colloid. So what cell am I going to find here? So what little cells am I drawing right there? Well, back in the day, they called them parafollicular cells before they knew what they did. So doesn't that just make perfect sense, right? These are going to be your calcitonin cells. So these are your C cells. These are really important in salmon. You know, when salmon have to do the shift and migrate into fresh water, turns out this is really critical for calcium metabolism from way back in evolution. Calcitonin actually is not physiologically important in humans. Why do I need to know that? Because if there's a cell, there's a neoplasm. If there's a neoplasm, it comes from the cell. So what neoplasm do I associate with calcitonin?
Medullary thyroid carcinoma.
Right? Exactly right. That's a really nice answer, right? So there's my medullary carcinoma. So is it a cancer of the follicular cells? No. Completely different heritage, completely different relationship. Okay? So when you are looking for your serum calcitonin as a marker of medullary thyroid, does it affect the person's calcium? No. It's just a vestigial remnant of back in the day when we were swimming upstream in fresh water. Okay? Okay, so when I say medullary, what's the next thing that comes to your brain? Medullary is a highly tested tumor, even though it's not terribly common. So why do we test it so much?
And syndromes.
Yeah, right. So this is my MEN2s. Okay, and it has a really cool marker, calcitonin. So that's really fun to talk about tumor markers. And then what happens as calcitonin builds up in the tumor? Watch what I'm going to write.
Starry sky.
Can you see beta? Can you see I'm writing a beta? Pleats. So what does that mean? Amyloid. Remember, amyloid, most proteins are alpha circular. When you beta pleat, all those proteins can stack and become insoluble, and so that becomes amyloid. Okay, so when you talk about tissue of the thyroid, the parafollicular C cells, they matter simply because they have a distinctive tumor in a very distinctive group of hereditary neoplasms. Okay.
That's a quick question.
Of course.
So when we have hypercalcemia, you can give saline and calcitonin to lower it quickly. If you get the high calcitonin with this type of cancer, do you also get low calcium?
No, isn't that disappointing? That would just be so friggin' cool if it would work that. And so what you're really talking about, Alex, is something you have to see in your head. Differentiate in your mind physiologic levels of something with pharmacologic levels of something. So when you go out and exercise and you get that beautiful exercise release of positive hormones, that's totally different than giving yourself cocaine for it. Right? I mean, almost everything you see that gives you pleasure comes out of that release. When you do it pharmacologically, you get disastrous pathologic effects.
The pathologic doesn't do it either on the medullary side, the medullary carcinoma side.
So the medullary will give you physiologic levels, not pharmacologic levels. Yeah. And so usually you're talking about at least 1 to 2 orders of magnitude more in dosing. So as you build into your mind this idea of physiologic, pharmacologic, yeah, they become different. Okay. So and you can apply that in life. It's what's called an emergent property. If you haven't built this into your understanding of technology, let's just stop and give you a more intellectual view of the whole thing. An emergent property says that as you increase something, it becomes different. So when you're following technology, let's just do this example. The first person to build a steam engine, James Watt in 1776, had to decide, well, how much work is my pump doing? And he looked around and said, well, it's normally done by horses. So he called it 1 horsepower. And then, of course, engineers are engineers. You knew it was a matter of about 6 weeks before some other engineer had 2 horsepower. But when you get to 25 horsepower, you know what you have? You have the Model T. So you get a car. So in other words, 25 horsepower is not 25 horses. It's an emergent property. And when you get to 50 horsepower, you know what you get? You get the Orville Wright plane. So when you think about emergent properties, that's the model that I teach them through. So when you think physiologic to pharmacologic, don't be surprised that you get emergent properties. Don't be surprised when you say something's pretty good and you come back 3 years later and it's 10 times better and it's totally changed how you think about it, right? When you go exponential, you get emergent properties. So physiologic to pharmacologic is a good model of that for us. Okay, so let's go now take a look at our follicular cell. So when you do your follicular cell, you're going to think about it this way and just always keep yourself oriented, right? There's nothing wrong with using colors. I'm a very big fan of using colors in my pictures because it always in your mind is how you remember it. So when you do a renal tubule, I always color it luminal yellow, blood red. I always do because I see it that way when I come to remember it. So when you talk about the normal follicular cell, you're always going to start, tell me about the non-luminal side. You're always going to draw 2 structures on it. So one's a receptor and the other's a channel. Okay, so what channel do I need?
Sodium iodide.
Very nice. Okay, so I have my sodium iodine symporter. And then what receptor do I need?
Thyroid.
Right, you need your TSH because that's how you're going to regulate it. Okay, so TSH is then going to be the stimulation to make thyroglobulin. And the symporter is going to what you need to bring in iodine. So the key step in the synthesis here is going to be iodination. And the iodination is done with which enzyme? TPO. So there's my TPO. So you can see there's 2 proteins you've got to have, and every time you think about thyroid, you got to have thyroglobulin. It's unique to the cell. No other cell has thyroglobulin. That's always really valuable in medicine. And no other cell has thyroid peroxidase. So every time you say thyroid, you're going to think thyroglobulin TPO. Okay? So then that's going to make my iodinated compounds, I2s here. And when TSH signals release, TSH is not only going to upregulate thyroglobulin, this is going to be connected to a lysosome for the finished product, and that's going to release T4. Okay, hashtag make me care. We don't learn crap because we're going to get tested by a PhD. We learn it because we're going to think of our patients this way. So let's go through and let's talk about the clinical situations we need to know this. Why do I need to know that there is an iodine symporter?
There's an iodine deficiency. They could end up looking like they're hypothyroid even.
Excellent. I like that a lot. So where do you see iodine deficiencies?
Far inland where people...
Yes, that's the first thing. You got to be away from the ocean because everything related to the ocean has lots of iodine. And the second is, it's got to be a third world economy because we iodinate lots of products. We iodinate all of our flowers. So it's very hard to do in America. So you have to come probably from one of the stands Kyrgyzstan, all those Azerbaijans, all those stands that you never can, ever sort them all out. That would be probably where you'd have to be, okay? I was thinking about nuclear weaponry. So if you're around a nuclear device, what is the key gamma emitter that sticks in the body? Okay, you want to differentiate in your mind when you talk about radioactive iodine. You want to differentiate between I-131 and I-128. I-128 is what we use in all our scans. So it's a benign, flushed out of the body, gone, no harm, no foul. I-131 is a hard gamma emitter. And so when you talk about Chernobyl or you talk about Hiroshima, you're talking about not just the uranium byproducts and the thorium byproducts, you're also talking about iodine because it sequesters, right? You're in that iodine and you get it in your body, it's concentrated in your thyroid. And the great sin of Chernobyl was the way you avoid it is it falls out like snowflakes. All they had to do was say, get inside. That's all they had to friggin' do was just say, go under a roof. And the first rain, it's all going to wash away. And the bloody government never told them. So everyone, especially the little kids, were all exposed to the snow. And all they had to do was go inside. So when I lived in Seabrook was the last nuclear plant built in America. And so we lived basically 6 miles from it, just on the seashore of New Hampshire. If the nuclear plant went all Chernobyl, even though it was a negative feedback loop, not a positive feedback loop, but if it went all Chernobyl, how were we going to handle that for our children before we could get them inside? Every public institution had what?
Iodine?
Yeah, that's right. In what form, do you know? Okay, it's a supersaturated potassium iodine. So every time you think about nuclear, and you are going to be caring for people, I presume, around nuclear plants at some point, you're going to talk about supersaturated potassium iodine. And so that's going to saturate the symporter for a long enough period to get past the fallout. So when they talk about nuclear fallout, it really is a fallout. That's literally true. So when you think of that symporter and say, hashtag make me care, you're going to think about how we do all our scans. There's our 128. And you're going to think about our nuclear weaponry, and that's our I-131. That's a hard gamma emitter. So can I treat, if I had a thyroid cancer and it had an uptake channel, could I treat it with I-131? Damn straight, works great. Works absolutely great. What's the great technical problem of giving my follicular carcinomas that have a channel? What's the hard part of treating them? Well, they pee it out, and they've now got a hard gamma emitter in their urine. So they have to come to an inpatient facility where you can keep that urine from going into the public system and let it decay long enough that it's safe again. So believe it or not, yeah, it works great, but you kind of got to go through nuclear exposure protocols. Okay, tell me how I should think about the TSH. What disease am I going to put right here? Right? I'm going to put my Graves, aren't I? And what am I going to write as the TSH? It's a TSH immunoglobulin, isn't it? So it's an anti-TSH receptor. It's an immunoglobulin. It's an IgG. Good? Okay. Tell me how I'm going to use these two guys in testing. How do I use these two guys in testing? Okay. Let's stop and talk about my hypersensitivities. Perfectly good time to talk about hypersensitivities. So when I talk about my hypersensitivities, how do we think about them? What's a type 1 hypersensitivity?
Mast cell degranulation.
Nice. And what causes the mast cell degranulation?
IgE.
Right. So every time you say type 1, you're going to say IgE because you have to be exposed and form it. And then you're going to get your mast cell degranulation, right? And then what's going to be my key product that comes out of that mast cell, Alex?
Histamine.
Good. Okay. So that's going to be histamine and the other vasodilators, bradykinin. Okay. So what? What's the effect of that going to be?
Vasodilation.
Right. So what formula have you got in mind? So if I dilate my TPR, what do I get?
Decreased blood pressure.
So every time you talk about your angioedemas and your distributive shocks, that's where you're going to put it in, right? So if you were going to write a question, what would be model diseases for this?
Peanut allergy.
Yeah, for sure, right? Peanuts are really common, 3 to 6% of all little kids. It's a really big problem. I've got a grandson with it. Bee stings are really good. All the Hymenoptera can do this. And I suppose if you want to get broadly talking, you can include asthma here too. Okay, good. Number 2, what's a type 2?
Antibody response, IgG.
Does that help you? But when I say antigen antibodies, where are they? Oh, geez, I got that totally wrong, Alex. I was in type 3. I got ahead of myself. You're absolutely right. The antibody targets tissue. So that means the antigen is fixed in the tissue. So every time we say antigen antibody, what's the next thing I'm going to write pathophysiologically? Why do we care about antigen antibody complexes?
The deposit.
Yes, yes, yes. Good. And?
Cause complement.
Good. So we're going to activate complement. Right? And when I activate complement, which complement is going to cause the next step?
C3A and C5A.
Really nice. And so that's going to cause, right? So every time you say antigen antibody complex, you're going activates complement. I've got neutrophils and monocytes, and now I've got all those friggin' protein, those proteases, and I've got generalized destruction. Okay? So give me some good model diseases of the antigens fixed in tissue.
Good pastures.
Okay, so antiglomerular basement membrane disease, good pastures. Yep. Watch this. Ooh, haven't ever done that one. This would be a good one to write a question on, wouldn't it? What did I just write? GP2B3A. Where do you find those?
Platelets.
Nice. So what disease is that going to be? ITP. Isn't that cool? So that's a really good example of 2/3 of your ITPs are to that one. You know what the other third is? GP1A. GP1A. The only other thing on platelets you know. So it works really well for 2 reasons to know them. First of all, because they are targets in diseases. But second of all, actually, they're the targets of autoimmune disease. Okay, smarty pants. What's this one?
Red blood cells, Rh receptor.
Right. So that's going to be, right? That's the commonest target for autoimmune hemolytic anemia. Isn't that fun? Okay, how about this one?
Oh, bullous pemphigoid.
Pemphigoid?
Oh no, vulgaris pemphigoid. Vulgaris pemphigoid.
Bullous. Whoops. So that's going to be my bullous pemphigoid. Hang on, my page is already.
That's right. The other one is the net-like one.
Isn't this a fun way to redo your diseases? You could do it from the patient or you can do it from the target of the antibody. Okay, so it's going to be to the hemidesmosome. Right? And that's going to be my, this is totally wrong. Let me get this right. I'm not paying attention. This is pemphigus vulgaris. And this is bullous pemphigoid. Okay, The next one you want to do is 3. Okay, in 3, where do we find the antigen antibody complexes?
It's deposited in tissues, like with certain glomerulonephritis.
So they're free floating in the blood. So every time you think about these complexes, you know what the next word's going to be? Where do they filter? What are the structures in the body that filter these antigen antibody complexes? And then we're going to go down the sequence of complement to inflammation. So you can see the difference. When I have a type 2, that inflammation damage is tightly focused to a specific organ. But now when I say type 3, whoa, that's totally different, right? That's going to be whatever filters. So go ahead, let's do, what are the structures that filter?
Glomerulus.
Absolutely. So if I filter in the glomerulus, what's my disease?
Glomerulonephritis.
Absolutely. Okay. Synovium. It's a filtering organ. So what am I going to get? Arthralgias and arthritis, right? You ready for this? Serosa. And I've learned I have to stop here and ask everyone, so what's a serosa?
Organ covering?
An organ covering. So it's a capsule.
Sure.
Okay, that's not bad, not right, but it's not bad. It's in the right general area. Anyone? Bueller? Okay, so you have to reshape how you think about the body. If you take a body and you draw how every time, and what this tells me is you know, go to a couple of autopsies. It's very difficult to do, but it's very useful to do. Because one of the things that you're going to really appreciate is when you take a look at a body, the body has this giant central cavity. And that central cavity comes out of the whole world of animal knowledge is called the coelom. C-O-E, coelom. And it goes all the way back to when we first became worms and we started to develop organs. All those key organs were kept in its own special compartment called the coelom. And when you take a look at us, we have the exact same preserved coelom that is divided by the diaphragm. So when you say coelomic cavity, you're referring to that whole structure that defines everything from our aortic arch all the way down to our internal genitalia. And you can see there are 3 linings for this. The linings are going to be the thorax, the heart, and then the abdomen pelvis. And when you look at them, they're shiny. So anything that you can see that wraps the outside and every organ around it, which is why you were partially right, Alex, it envelops every organ in the coelom. But remember, it also does the whole outside of the coelom. So we always have a visceral and a parietal, and everybody slides really nicely on everybody. So when you talk about what this means grossly, it is a serosa. But when you have a pathologist look at it microscopically, what's she going to call it? She's going to call it a mesothelium. So when you look at it, a surgeon calls it a serosa, but a pathologist calls it the histologic name, which is mesothelium. And of course, this is a huge discussion because this is all of our effusions. So when I say pleural effusion or pericardial effusion or ascites, in your mind, you're building a coelomic cavity, dividing it by the diaphragm, and then saying visceral and parietal mesothelium serosa, just depends whether I'm microscopic or gross, and that's how you think of it. So when I say serosa can filter, then you know you're going to get serositis. And the 2 commonest serositises we see are going to be pleuritis and pericarditis. Okay, another thing that filters are blood vessels. Vessels actually really are pretty good filters, And that's going to give me vasculitis. And the last organ that filters in the body is going to be the basement membrane of skin. And so that's going to give me rashes. Do you see what disease I've just described?
Lupus.
Yeah. So when you say, what is the diagnosis of lupus? Lupus has 11 criteria. If you have any 4 of them, that is diagnostic. So the only other things I have to add in here are basically going to come out of lab testing. I'm going to have ANA. I'm going to have the specific antibodies. And I'm going to have the hematologic autoimmune hematologics. So when you look at that, all of a sudden you realize when I learn how to filter and create inflammation, I'll never ever have trouble recognizing lupus in my mind anymore. Because if you have an ANA and any one other test, all you need is a rash and sore joints. Well, doesn't that work nicely? Okay, so let's just talk while we're here. Let's just deal with our lab testing, okay? When I say ANA, how do you think about ANA? It's sensitive, okay? So ANA is your sensitive test. If that's negative, you don't have lupus. There are 2 others that you have to know. The 2 others that you have to know are going to be anti-double-stranded DNA. That's one of them. And the other one is anti-Smith. So anti-double-stranded DNA, that correlates to the glomerulonephritis. If you're going to have, and that's how they die. When you say, what's the most serious in all this? That's how they die. So you're always very keen when you see any hematuria, man, you really want to know about the anti-double-stranded DNA. And then anti-Smith, that's the most specific. So if you have some vague symptoms and signs and you're really not sure and they're ANA positive, that's great. You can't rule it out. But if you can get anti-Smith, it is lupus. I suppose if we were really going to, because you're 4th years, I'll add this in. You can also do the antihistones, right? Because that's going to be from a drug. I don't normally do that with my 2nd years, but you guys should do that. So type 3s are a really fun one to talk about, aren't they? Because all of a sudden you realize lupus is the disease. And so you walk through this whole discussion and you've really got one of your really important diseases, really nicely pathophysiologic. Well, those are all antibodies. Now we come to the ones that pathologists really love, because now we're talking about the type 4s. So when I say type 4, watch what I'm going to write. And I really like doing this because it drives every PhD immunologist insane, because there's a real difference between going with the theory of immunology and clinical immunology. Man, if you're clinical immunology, what do I mean when I say T-cell mediated? I want 2 pathophysiologic processes. You watching? If you haven't done it this way, it really works great. Cytotoxic lymphocytes. And of course, if I add in interferon gamma, that's going to be a granuloma. Isn't it? Well, this is a whole world, right? When you get into non-infectious granulomas, man, that goes forever. From sarcoid to vasculitis to all sorts of things, okay? But what I want to talk to you about, which is what brings up our discussion today in antibodies and thyroid, is I want to talk about the cytotoxic lymphocytes. Because here's what you've got to think about when you do adaptive immunity. Have you ever done a quick and dirty how to think about adaptive immunity? Should we just do a quick one? How do you think about it? Because you really need to do it to understand how this is all going to work. We start, remember, always and ever with acute. And when I get an injury, I'm always going to create an antigen-presenting cell, which is always going to have it on MHC2. Okay, that's just how it always is. But what you want to think about is how this goes from the site of injury to the nearest draining lymph node. So when I say lymph node, I expect you to be thinking about this. There's my lymph node. So my antigen, here's my antigen presenting cell, and coming out, here are my antibodies. So every time you think about adaptive immunity, you're always starting with innate immunity. Adaptive immunity doesn't do anything unless I get an antigen-presenting cell, which is classically a resident macrophage or one of the other cells coming from the injury site. So every time you think about adaptive immunity, you're always doing this. And those little blue dots, that's where all your naive T cells are waiting to match their cognate antigen. So every time you talk about immune response, you're doing innate, which we've done, right? It's all friggin' pre-programmed. And then we give an APC to my naive T cell waiting in a primary follicle. That's how you always think about it. And when we talk about what happens, so here's my antigen presenting cell and how it's going to my naive T cell, you're always going to think about how does it activate it. You're always going to build into your brain 3 signals. This is big picture stuff. The first signal is to the TCR. We won't go into how that actually works, but that's where the cognate receptor is to match up to the antigen presentation, and that starts the machinery. So that's the first thing, that matching to the TCR, that is signal 1. The next thing that has to happen is at the site of inflammation, I not only get MHC2, but I'm also going to get my B7 antigen. I have to have authenticity that I'm not just some random guy presenting proteins. I really am coming from damage. So my B7 is going to match to my CD28. And if you don't, so that's signal 2. And signal 2 is where you always build in your idea of energy. That presentation has to come from injury. Got it. Okay, but now all of a sudden we come to the guts of this matter. What does the TH0 cell become? Is it going to become a TH1? Is it going to become a TH17? Is it going to become a Treg? How does it know? How does it know which machinery? Every naive cell has all the machinery. How does it know which one? Or is it going to assume the default of a TH2, and that then is going to go on with my B lymph, which is going to make my antibodies? How does it know? How does it do that? Yep, cytokines. Okay, and this one set of cytokines you're going to learn is going to be this one. In signal 3, it's going to bathe that cell in cytokines. And if it's going to be coming out in a TH1, signal 3 is the one you're going to learn. That's going to be IL-12. And you can imagine all the others have different cytokines. And you can go look them up. I've got a nice list of them on the website. You can go look them up, which ones are TGF-beta and which ones are IL-1 and what combinations. And good God, give me a heads-up display. I'm not going to learn that. But you should know that there is a signal 3. So even if I'm going to make a TH1, and that's going to make my interferon gamma and create my activated macrophages, it's got to be created out of a naive T cell. If you say, well, what creates my TH2, you should always think of this one as IL-4. What I want you to see from this picture is, first of all, there's 3 signals. So if you haven't said to your mind, there's no adaptive immunity without acute inflammation. There isn't. And how does it communicate to that naive T cell? You're always going to learn signal 1, signal 2, signal 3. But when we come to cytotoxic lymphocytes, right, look at this. So here's my cytotoxic lymphocyte. But you'll notice there's a default pathway to Th2. There's no such thing as a pure pattern of disease. Every time you get a cytotoxic lymphocyte, you're also going to get an antibody. So if I can find an antibody that's specific to a protein, then I have two ways of diagnosing my type 4s, don't I? I can do a biopsy and actually see the lymphocytes damaging the cells. Or I can look for the antibody and find a specific protein. I'm going to use both of those in my type 4 hypersensitivities. Okay, you think I'm just blowing smoke here, right? Okay, watch what I'm going to do here. I mean, this is so good. I really should have a surcharge on this. I mean, I hate for you guys to just be given this gift, which would have helped my life so much. Every organ has an autoimmune type 4. It really does. If you haven't played this game, it's a fantastic game. So I'm going to name the organ and you tell me the disease. Fair? Watch how good this is. Okay, let's start with brain. And remember what I'm saying. If I biopsied the tissue, I could see cytotoxic lymphocytes with its granzymes and porons and with its FAS. I could see I could see it literally killing the poor cell. Brain? Multiple sclerosis. If I biopsied the brain, can I see cytotoxic lymphocytes killing it? Yep. And can you tell me the protein it targets? Myelin. Huh. How good is that? Okay, well, let's just keep going. Peripheral nervous system. Oh, Alex, I'm really disappointed. I thought you'd be much better at this game than you are.
Guillain-Barré?
Oh, that's so good. Guillain-Barré. Okay, let's give you an easy one. This will just cheer Alex up. He's pretty depressed because he thought he'd be better at this game. Let's give him an easy one. Remember what I'm saying. I can biopsy the gland and see lymphocytes. If I do a fine needle aspirate of this thyroid tissue, what am I going to aspirate?
Hashimoto's?
Nice. So now you know, if you do a fine needle aspirate of a irregular hash thyroid, what are you going to get on your cytology? Friggin' lymphocytes. Oh, but do I have a protein?
Thyroperoxidase?
My two specifics. And what was the other specific protein?
Thyroglobulin?
Nice. So you're going to see, you can use antibodies or biopsy to prove it, can't you? Okay. Just watch how good this is.
Sjogren's disease?
Absolutely. And what are my antibodies? They're not very good.
Law.
Right? They're not very good ones. Okay. So Sjogren's is the whole exocrine world, right? So it's not just the thyroids. It's also all your exocrine glands. Okay. If you were unclear on the diagnosis, could you just biopsy to prove it? Can you just biopsy the tissue and show that it's got inflammatory destruction of the salivary gland? You can, but what's the trouble of biopsying a salivary gland? They leak forever. So it's just like the pancreas, man. It's just a bitch to deal with them surgically. So how are we going to get salivary tissue without going into a major gland? Well, it turns out, just a nice way of thinking about this, only about 60% of your saliva is your large glands. The other 40% are from your minor salivary glands. Take your lip, run your tongue around your lower lip. Feel all those little bumps? Every one of those little bumps is a minor salivary gland. So I don't think a month of my life went by that I didn't get just this little snip. It's easy to do. You freeze it up, one stitch. It's as easy as pie. I didn't get a minor salivary gland as a way of proving Sjogren's disease. Okay? Good? I'll give you a hint. It attacks the myenteric plexus.
Achalasia?
Nice. Okay, we're going to get into common stuff now.
Pernicious anemia?
Very nice. And do we have a protein? It's got to be specific to the cell, or it's too non-specific. What protein is specific to the parietal cell?
Intrinsic factor?
Nice. So isn't this a great game? Okay, watch this one, you guys. Duodenum.
Celiac.
Nice, Alex. Now you're firing up. It must have been not enough coffee. So that's going to be my celiac sprue. Do I have a specific protein?
Tissue transglutaminase, something like that.
It's a fantastic test. This is one of the two most underdiagnosed diseases in our society. One of them are the heterozygote LDL receptor deficiencies, massively underdiagnosed, and celiac is probably 1 in 200. We don't remotely do this. So getting really good with your anti-tissue transglutaminases is really worth thinking about. Okay, when I say liver, we have two different types of cells. We have the hepatocyte, and we have the biliary tree.
Primary sclerosing.
So in the hepatocyte, it's anti-autoimmune hepatitis. And this is where we do our...
Antimitochondrial?
No, biliary tree. This is our anti-smooth muscle. In the biliary tree, what's our disease?
Acute biliary sclerosis?
Primary biliary cirrhosis. And this is where we have our anti-mitochondrial antibodies. Okay? So when you take a look here, you can see how really, really useful that type 4 discussion is. Isn't that just a totally great discussion? And you realize that now you have, every time you think of these, and every organ has one. So you're always saying, do I need to biopsy to prove it? Do I have a cell-specific protein that I can go looking for? Because the default position, no matter how perfectly it starts out as a Th1, you'll always end up with some Th2 activity. It's never either or. Everyone good on that? Okay. So, wow. Isn't it fun how fast this goes? Okay. So when we come to this one, this is going to be a type 2. Oh, I know what we were doing. We were talking about how to think about the thyroid cell, and we got distracted. Okay, so then here all of a sudden you say, tell me the tests I need here, right? That's going to be my Hashimoto's. Okay? God, that's the cutest cat in the friggin' world. Now, when we go to drugs, so if you want to treat your Graves' disease, remember that we can target TPO. So how am I going to target TPO with drugs? If I have a hyperthyroid patient from Graves and I want to think about my choices, how can I shut down thyroid production by targeting TPO? Right? Methimazole. And if you were taught by someone who is out of date, you probably heard about PTU. Okay? But those are both TPO drugs, and of course that shuts it down. And remember we said that what they hate the most is the sympathetic nervous system. So if you have a beta blocker and methimazole, that's the medical treatment of hyperthyroidism. So you can appreciate when we come to this disease, again, it never changes in life, does it? You have to say, how does a patient present? That's one track you always talk through. And then the other is just tell me about the organ system. Structure, function, adaptation, pathology. Okay? So now when I say to you this case, now all of a sudden you realize all the basic sciences that really help you manage it. Isn't that good? And it's just worth it. So, I'll send you out the pictures today. Just sit down and copy them out and practice them. Take a picture with your phone, put it in your file. Every time you're being bored to death by blah, 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 just kind of sit down. It's so pathetic. I mean, I'm so pathetic. I'm embarrassed to say this, but it'll give you cold comfort. Sometimes when I can't get to sleep, I do these pathways in my head, and for sure I fall asleep always. Okay, everyone happy with Graves? Okay, we're going to finish up Graves right now with a very quick picture, because it's an important way of testing teaches pathophys. Here's what I'm going to give you, okay? And then you can all have your weekend. I'm going to give you a hyperthyroid patient. So by definition, low TSH, high T4, okay? But what I'm going to do is I'm going to do a thyroid scan. So when you read about your radioactive iodine uptake, and then we also get a picture, so we're going to do a scan. This is going to be my iodine 128. Okay, I'm going to show you the picture. You tell me the disease, and then you can go home. So remember, it's hot, cold, black is hot, white is cold. That's sort of just by convention from back in the silver film days. Okay, so here's my thyroid. Well, I'll give you a pyramidal lobe just because we talked about it. Okay, this is what your scan shows you. And this is the normal size of the thyroid.
Graves?
Okay, that's a nice answer. Tell me why that must be true.
You have diffuse enlargement and production.
Okay, always a feedback loop. TRH, TSH, right? So when you say, what is Graves' disease? Graves' disease is this. So you're literally stimulating every cell. So if you're looking for a model of hyperplasia, this is a great model. So every time you look at a hyperthyroid patient, you're always looking for two things, right? Thyroid is always diffusely enlarged, every cell is stimulated, and then extra thyroid, eyes and shins. Good, really nice.
Toxic adenoma.
Okay, tell me the two findings here, Alex.
You mean on the scan?
Yeah, you need two findings.
There's
one. So it's autonomous benign neoplasm. Yep, what's the other one? All the rest of the gland is?
Non-producing.
Negative, because what we've done here, right, what we've done on this one is going to be, that's all we've done here is we've done this. So literally, we're going to have a decrease in TSH. So to have a good functioning adenoma, you not only want to find the hot spot, you want to know that it actually shut off the normal system. Okay, and here's the last one. Remember, this is a hyperthyroid patient.
Exogenous use?
Hashimoto's.
I like that a lot. So that could be exogenous or?
Early Hashimoto's.
Nice, really nice. So in exogenous, you got into mom's pills, and in early Hashimoto's, you were released from physical destruction, releasing preformed in the colloid. Okay? All right, nice stuff. So we'll come back on Monday. We'll sort of keep on. Is endocrine going okay? Or are you guys bored to tears and we should shift?
I wouldn't mind going to a different organ system like lung or liver. I feel like if it's our last week, I'd like to get a well-rounded path versus a deep dive.
What's everyone else want? I mean, yeah, obviously, I feel like it's good to do. It's very useful stuff. What I would suggest is this. Have we gone through chronic diabetes? Have we done complications of diabetes?
Not yet.
Okay,
not
good.
yet.
Tell you what, Alex, here's the deal. We'll do complications of diabetes and then go to lung. complications of diabetes is just worth it. I mean, it's you know, as someone told me, every third question of every exam is diabetes. So let's do complications of diabetes Monday. I mean, you can follow the rest of it. I'm just going to go from HPT to HPA, right? And it's going to be up, down, and oh, okay. I will let you get out of it if you answer this. I didn't even think about it. All right, here we go. Watch this. So we're in type 4 hypersensitivities. Watch this, baby. Adrenal.
Acute adrenal insufficiency?
Not acute, because by definition, this is adaptive immunity. Get the rhythm of the disease right, Alex. To kill something acutely, it's either got to be acute inflammation or vascular or chemical or toxic. If I'm doing cytotoxic, it's always a disease of months to years. Okay, so what disease of adrenal insufficiency is months to years?
Addison's?
Okay, excellent. But here's what I really wanted to make fun. Is there a protein? I just found this out the other day. So it was so fantastic. I just loved it. Because you guys actually really only know one protein in the adrenal from congenital adrenal hyperplasia. What's the commonest deficiency in congenital adrenal hyperplasia?
21 beta hydroxylase?
Absolutely. So guess what you find before you even get the insufficiency? Anti